97.1 FM Talk Podcast.
This is Eye on Health with Dr. Michael Jones.
Welcome back, St. Louis. This is Eye on Health. My name is Dr. Michael Jones. Thanks for tuning in. The weekly healthcare-related show here on 97.1 FM News Talk. In studio, as always, got Eric Robert from
Redbud, of course.
From Redbud.
Just drove by your office yesterday, as I was telling you.
Wow, I bet you were amazed.
I reminisced about all those trips in as a young kid, you know, to go see your brother, Eric, who was my eye doctor ever since I was knee-high.
Yeah.
Yeah.
You're making him feel very old.
Oh, well,
I'm
you know.
sure he appreciates that.
Yeah. Anything I can do to help.
Hopefully they were fond memories.
I don't know if listeners realize that, but you guys, just coincidentally, really, were my eye doctor all the way up, you know, whenever I wore glasses, until you permanently took care of the problem with LASIK surgery. I don't know.
That's a nice segue, I think.
8 years ago, something like that.
The very nice segue. I like how you did that.
See how that worked out?
Yes. But yes, we have very few patients in Illinois escape
That's
us.
right.
To get all of them. I also want to welcome in studio a very special guest today, Dr. Joe Ojile. Dr. Joe, thanks so much for coming in today. We really
Thank you for having me. Looking forward to it.
And Dr. Joe is one of the few guests on the show that I actually want to put you to sleep. I want him to be so soothing that he puts you to sleep, because Dr. Joe is a sleep specialist. Is that right?
That is. We do sleep here in St. Louis, but don't be driving when you go to sleep. Remember that.
Yes, he's appeasing all the lawyers that are listening, and thank you for that disclaimer. And I've got to start the show by saying, USA, USA. Because just as I was driving in, I don't know if any of you heard or saw, our local boy, TJ Oshie, scored the winning goal against the mighty Russians in a shootout. A very dramatic goal. So check out the video. It's pretty crazy, and it will make you very proud to be a St. Louis Blues fan. And, by the way, Eric, did you notice me and Dr. Joe both today?
Look at that. Yeah.
Both got our Billikens garb on. We're ready for the 1 o'clock start.
We are decked out for the Billikens game. Dr. Joe, are you nervous? Are you excited? Scared?
I'm excited that ESPN for St. Louis University, that's really a great accomplishment, and this seems like a great group of young men. It's
amazing. What a year they've put together, and it's one of these stories. A lot of times, Dr. Joe, on this program, we'll talk about stories that are either being miscovered or undercovered by the media. Have you ever seen such a team go underreported? It's amazing. It's like they're more famous outside of St. Louis than inside, but they put together a tremendous run this year. It's amazing.
Yeah, Bobby Knight's comments, I thought, were really very gracious and telling for such a nice group of athletes. He was quite complimentary of them this week, so that it should be good. I think he's announcing the game for them.
Yeah, he's announcing the game, and Coach Cruz is a disciple of Bob Knight, and I think that's one reason maybe why this team doesn't get so much coverage. There's not a lot of flash, not a lot of hype with them, but they play good old-fashioned man-to-man defense, which is pretty amazing. But check out the game today. If you haven't seen them all season, this is the day to watch, and hopefully they can continue their winning streak, which I believe is at 16 games now.
Yep, 16.
Holy cow.
Should be an exciting day.
And they're up to number 12 in the country. So go Billikens. We'll at least talk about it on this show here.
There you go.
And if you guys could see us in studio, we're all decked out in our Billiken garb except Eric.
Well, I got the gray.
It's gray.
Yeah, you know.
And, hey, speaking of sports, stop the presses. There's something very important we have to talk about. Bob Costas' eyeballs.
That's right.
I mean, here we go. We got
speaking of good segues, holy cow.
Yeah. Hey, did you? I'm learning from you. You're
that's
teaching
nice.
me. That's really good. So the number of times I have been contacted this week alone to speak about Bob Costas' eyeballs, it's way more than the last time I got asked to speak about his eyeballs. But every day this week, we have been on radio and TV talking about Bob Costas' eyeballs. He has viral conjunctivitis, Dr. Joe. I mean, it's a medical mystery what he's got. But what's funny is how they were trying to pin it on maybe, the poor conditions in Sochi, or, he's drinking bad water. He looks like he just picked up a case of conjunctivitis, and it'll get better on its own. But the way the media was treating it, you would have thought he had, cancer or something.
And that viral pink eye is terrible. I got that 2 years ago, I think, and We had a 6-month-old at the time, so I had to quarantine myself to my parents' basement.
Absolutely.
Oh, it was just bad.
So when I was going on the radio talking about it this week, it did allow us to bring it up because it's something that's so mundane. Sometimes we don't even talk about it. It's extremely contagious, and it's just the virus that causes a head cold, adenovirus most of the time, and you can pick it up just from a door handle. If someone comes into one of our eye clinics with it, we have to bleach everything to prevent it from spreading around. It's extremely contagious. So what I was trying to get home, the point I was trying to drive home this week was, first of all, it'll go away on its own. Throwing antibiotics at a viral conjunctivitis isn't going to do anything. It will go away on its own. And probably the most common question I got was, well, surely there's some miracle drug here in the States that if Bob Costas was here in the States, we'd give him this miracle drug and it would go away. I was like, no. You just got to let it run its course, right?
Your prescription would have been time off work.
That's right, time off work, which is what he's getting now. So first of all, it will run its course without antibiotics. We've talked about antibiotic overuse on this show multiple times. And then the other thing I wanted to stress was how contagious it is. Do not share towels. If you share towels, you'll spread it all around the house. Actually, you should change your own linens very frequently because you could reinfect yourself. And we've seen cases of this, which should resolve within 2 weeks at the maximum, go for 2, 3, 4, 6 weeks even because they keep reinfecting themselves. So if you get a case of it, just make sure you're changing your linens out frequently, as I know Bob is doing. I'm sure the NBC staff has him well taken care of.
Mentioning pink eye is like talking about yawning. My eyes start to feel nasty just thinking. It's so bad. I don't know if you've had the viral version before.
They're looking pretty bad.
Well, yes, I bet. See?
That's not viral.
Yeah.
No, I've never had viral conjunctivitis, knock on wood, even though I see it all the time. That's because as soon as I see someone with it, I just run the other way.
That's the best answer. Yeah.
It's the second paragraph of the Hippocratic Oath. If you see someone with viral conjunctivitis, as a doctor, you just kind of run the other way.
Right.
Let them go to Walgreens and have someone there take care of it.
This looks like a great case for the Take Care Clinic.
That's right. Absolutely. Actually, I yell it from across the room. Go to Walgreens. Hey, did that sound good?
That was nice. Good.
Anyway, so Bob Costas' eyeballs were very big in the news. That's it. Just viral conjunctivitis, folks. There's more important things going on at the Olympics, like TJ Oshie scoring a game-winning shootout goal. A shootout against Russia sounds kind of scary to me. But he scored a game-winning shootout goal. That was a joke, by the way.
That was good.
I got a little bit of a chuckle
They
there.
didn't bring in Putin to play, did they?
He was probably playing goal with his shirt off. All right, guys, when we come back, now's the time to call in. We've got our sleep expert on, Dr. Joe Ojile from the Clayton Sleep Institute. Is that right? Clayton Sleep Institute. When we come back from break, call in. He's going to answer all your questions, so stay tuned.
And we're back with more Eye on Health with Dr. Michael Jones.
All right, welcome back. Thanks for hanging on through the break. This is Eye on Health, the weekly healthcare-related show here on 97.1. I do want to give a thanks to our guest last week, Dr. James Briggs. Dr. Briggs was from the Medically Supervised Weight Loss. He had a great show. Just fantastic information, very interesting conversation. Thanks for all the nice emails everyone sent in over the last week asking him questions. I really appreciate it. And today we have another fantastic guest on, Dr. Joe Ojile from the Clayton Sleep Institute. Dr. Joe trained at St. Louis U, and we've been talking about it all morning. Go Billikens. And Dr. Joe, I want to thank you for coming into the studio. Welcome to Eye on Health.
Thank you.
And if you've got calls, Eric, what's the number to call in here?
314-969-9797 or 866-455-9797.
I could never remember the numbers because I don't get enough sleep at night, Dr. Joe. And then if you want to find out more about Dr. Joe Ojile and his practice, go to ClaytonSleep.com. All one word, ClaytonSleep.com. They've got several offices, 2-3 offices in the area.
We're in South County, Tesson and Lindbergh, and on Big Bend and Highway 40, 2531 South Big Bend. And we also have testing facilities in De Pere at Doherty Ferry and 270.
And the phone number to call is 314-645-5855. to call in to get an appointment with Dr. Joe and check out his website at claytonsleep.com. And no joke, sometimes when I don't get enough sleep, I do have trouble remembering things. Is that a pretty common problem with lack of sleep?
It's quite common. Actually, as you would know as a physician, it's the first thing that goes is your memory and ability to remember if you don't get enough sleep. So certainly check out the sleep patterns of your surgeons before you use them. We were talking off air. It's a topical thing with the Olympics. The athletes are now incorporating sleep health as full part of their training programs. Some of the Olympic teams actually have hired sleep consultants to help them in their training process. So they're now working on both their diets, exercise, and their sleep health as the trifecta of what they work for training.
Now, Dr. Joe, as a physician, I got to tell you that sleep is really it's an intriguing topic. We aren't really well trained on it in medical school. And what are some of the things, like what's a typical patient that would come in and see you?
So our patient population will skew in two areas. First of all, I'm also a pulmonary doctor, so half of our practice is lung disease, but and sleep and breathing is part of how that got incorporated. So we'll have people that have sleep and breathing issues, so things like obstructive sleep apnea, central sleep apnea, and the like. We also are driven by people who will come in and say, either I just can't sleep, or the reason we sleep, one of the big reasons, is to feel better and be rejuvenated for the day. So they will come in and say, I sleep, but I'm always tired or sleepy during the day. And that will start the process of the evaluation.
So as a physician, I would think the person I would send to a sleep doctor would be the typical obstructive sleep apnea type patient. But you will see people who are just having problems, just going to sleep. And that's a great segue because I think we have a caller on the line with a question.
We do. Kim, you are on the air with doctors. How are you?
Good. How are you this morning?
Doing fine.
Good. I had a question for Dr. Ojile. My son is in his late 20s. He's an Iraq war veteran, and like so many of our veterans, he has a horrible time sleeping. When he is able to sleep, he has nightmares and the like. Do you know why it happens and what to do about it?
So first of all, thank you to you and your son for his service. We want to make sure they feel our full respect. This is not an uncommon situation, which you alluded to. First of all, the individual, we'll call them a patient, but the soldier has to be treated in a private and confidential way because there's frequently one of the first issues of things such as post-traumatic stress disorder. One of the first things that will show up are sleep issues before any of the other symptoms. So before anything else is done, they should have a private consultation where a full evaluation of when these things started and what might be going on. Some of it may be remembering things in the past, or as they go to sleep and relax, some of the issues come out, even in dream ideation, things like that. So there are some behavioral interventions that can be done. We have a team that helps with those issues. I think they have that at the VA as well now. They've become more sensitized to some of the issues of our returning war veterans. Just because the person's a veteran, though, they may have other sleep issues, things like obstructive sleep apnea or insomnia from a behavioral or familial perspective, meaning that there's people in your whole family, his whole family, that have had difficulty with this as well. But we just have to work through it. It's usually a combination of behavioral therapy first and then medication if needed.
Okay.
I hope that's helpful, and please feel free to reach out if there's any way we can help your son. We certainly respect what he's done for us.
All right. Thank you.
Thank you.
Thanks for the call, Kim. And Dr. Joe, let me ask you, from what I remember, there's a difference between having trouble falling asleep and then having trouble staying asleep. And do people is that one of the breakdowns that you look for? I mean, is that one of the main things you're looking for, like in a patient like him who we may jump to the conclusion that it's PTSD, but as you said, it may be something that's organic going on in there.
It could be. And remember, we would classify PTSD as organic. Really, I mean, at the end of the day. So there's the definition of insomnia, as you allude to, is the inability to get to sleep or stay asleep with a daytime consequence. So what we didn't, this young man's probably feeling fatigued during the day and having other issues. But people have either sleep initiation insomnia or sleep maintenance insomnia, trouble staying asleep, and some of them have both. So we have to go through the process of eliciting that whole symptom pattern and try to figure out what's causing it, if anything, obvious. Sometimes it's behavioral, but there may be other things. So some of the big things we see now, we're starting to see more and more difficulty with chronic pain patients. Pain is one of the most disruptive things to sleep. So we'll work through that with the patient. So we start the differential of trying to come up with what are the reasons the person is having difficulty, how long has it gone on, what might have been an initiating factor, and then try to structure a personalized solution. Because the key with this patient population is you have to have personalized, individualized care.
One size does not fit all.
One size
can't
does
throw
not.
a CPAP on everyone and fix everything. That's
got
what I thought. That's all I thought you did.
Right, well, there's so do my children. So that's what takes the effort to sit and really, and it's quite rewarding to sit and talk to a person and have them share those aspects of their life and try to figure out a program. And we have a team that does that sort of work because one person just can't do all that.
Along the lines of the chronic pain, I actually saw a study just this week, I think, about how restorative sleep is in patients who have chronic pain. If they're not getting enough sleep, it actually makes their pain even worse. So not only is the pain keeping them from falling asleep, have you seen it where it's actually making their pain even worse during the day?
Yes, that's you're right on top of the latest.
I am the smartest man alive!
We're going to give you a vote right now. The poor sleep, for whatever reason that you're getting the poor sleep, reduces the pain threshold. So what that means in layperson's terms, right, is they perceive pain more severely. So if we can improve people's sleep quality, then in turn what will happen is their pain won't resolve. One of the things we tell people, doctor, all the time is we can't cure what ails you, but we can help all the things that ail you. And this is that case where if we can improve their sleep quality and their sleep time, they'll feel better during the day and they'll still have pain, but it won't be as severe. So we do a lot of work for people who do chronic pain work, rheumatology work, orthopedic work, because what they'll start to uncover is these people are sleeping poorly. The worse they sleep, the worse their symptoms become, and they become intractable. Sometimes we need to improve their sleep to break the cycle.
That's great. We had a question on the line. It's dropped off. What role does I think the question is about what role playing does it play to remove the tonsils or the adenoids for sleep?
So we have to split that out into children and adults. In children, we're seeing a marked increase in the amount of young children with obstructive sleep apnea from ages of 16 down to 6 months. Most of the time, surgery is the first-line therapy. They're removing the tonsils and the adenoids, and these children do fantastic. It should be part of the evaluation of children who are being looked at for things like ADD and ADHD, because a sleepy or tired child, how they behave during the day is they are hyperactive, can't pay attention. Does it sound familiar, right? Act out. So that's
me.
So the symptoms are the identical to that. And there have been several studies that have shown repetitively that up to 20 to 25% of young people with, quote, ADD or ADHD may have obstructive sleep apnea.
Amazing.
So it's worthwhile having that evaluation done.
Amazing.
In adults, for surgery has become less popular because when you take all comers for surgery, it's only successful in about 50 to 60% of the time. So most, even surgeons, look at surgery as second-line therapy in most patients unless they have a jaw abnormality.
Okay.
And you quite frankly may see those patients being an ophthalmologist in what you do, because you may see them having retrognathia where the jaw falls back and so forth. So in some of those people, surgery can be more beneficial.
Okay. Real quick before we go to break, I saw another study. Look how much research I did. Aren't you impressed, Eric?
This is very nice.
I saw another study actually this week alone that if you lose 5% of if you have obstructive sleep apnea from just being overweight and you only lost 5% of your weight, it can basically be curative of OSA? Is it?
Moderate amounts of weight loss, 5-10%, can cause significant improvements. What we tell people is they don't have to go on the supermodel diet to make things better.
Just a little bit helps. All right, stay tuned. We got more with Dr. Joe Ojile from Clayton Sleep Institute when we come back.
Could this be magic? Or could this be love? Could this turn
This is Eye on Health with Dr. Michael Jones.
Welcome back. This is Eye on Health. My name is Dr. Michael Jones. Thanks for tuning in. Every week, 10 to 11, we're talking all things healthcare related. Today, we're talking something near and dear to my heart, sleep, with Dr. Joe Ojile from the Clayton Sleep Institute. Boy, just a ton of great information here so far today. Thanks so much for coming on, Dr.
Thanks for having
really
me.
Appreciate it. We could probably talk for 10 hours about this stuff and to still not get to the bottom of it. So we're probably going to have you back on to go over this stuff again.
That'd be great.
We do appreciate any questions coming in because that really does help drive our conversation. I have a question for you, and Eric will remember this. We had a guest in studio talking about the effects of light and radiation from our iPads, iPods, TVs, computers, and how that's disrupting our sleep. From a medical doctor standpoint, is that real? Is that out there?
It is real, and it is epidemic. And we're actually seeing patients, especially parents, bringing in their children for this very thing. They come in because the child is tired during the day, or not. They can't get the child to get up. And these are high school and college age children, and in some grade school, like junior high children and young adults. They're using their light-driven computer devices up until bedtime, including after midnight. Highly stimulating. So the two things that will stimulate the wake system are stimulation such as shows, right? The actual intellectual power of looking whodunit or an exciting show and whatnot. And then number two, light is one of the most stimulating things for wakefulness. So the light coming from the computer screens, especially desktop computers and big laptops, are highly stimulating, including TVs. And then the third thing, as an asterisk for the third thing, are the smartphones. Because now that texting has become so inexpensive for all families on these family plans and so forth, there's a lot of good things that happen from that. But we need to take the phones back about an hour before bedtime, because even at the junior high level, children are sleeping with their phones. And there's been repeated studies done both through the National Sleep Foundation, and we have actually done studies here in Missouri with our organization. We did a junior high school, unpublished data, but we did the data. 66% of the children in a junior high school were sleeping with their smartphones. And so it's incredible. And so when you think about it, if you watch teenagers and high school and college children, they wake up to every text message. It dings them in bed. I'm exhausted just watching them. I don't know how they function the next day.
Oh, one of the best features, and I don't, other phones may have this too, but I know they added a feature to the iPhone in the last year or so called Do Not Disturb.
Yes.
And for mine, it automatically kicks in at 8:30, and it doesn't kick off until 7. Even though I'm up way before that, I just don't want to get it before that.
Thanks for sharing that. That feature is a response to part of what we're talking about. So I appreciate you bringing that up. I was going to throw that in. That is the kind of thing we're starting to see manufacturers and app makers begin to respond to sleep needs. As thankfully, you fellas having sleep as part of your program, awareness increases. We're starting to see the manufacturers, and that is a really good feature for us as adults because we want our phones so that if there's an emergency, we can get a call, but you don't really need the other calls or texts.
And I've got 3 people set, including my wife, where if they call, it goes off. But outside of that, I it can wait.
Yeah,
I'm afraid my phone would miss me too bad. Don't listen to them phone. But tell me more about this feature. It's something I can easily turn on.
It is actually, I can show you real quick because you have an iPhone. I mean, it's whenever you swipe up from the bottom, there's a little moon there. It looks like a crescent moon, and if you press that button, it'll put it in Do Not Disturb.
I see it here, the moon. Okay.
Yeah.
I was afraid what was going to happen if I pressed that.
Nope, it just means it won't it won't buzz, it won't ring.
Was going to come
yeah,
up.
people can still call you, send you messages, that sort of thing. You can still look at them, but it's not going to notify you with a ring.
Very important feature to have. I think we've got another caller on the line, Darren.
Darren, you're on the line.
Can you hear us, Darren?
Yeah. Hey, how you doing?
Good. How are you?
Hey, pretty good. I just wanted to call and maybe raise some awareness also for one of my statements, I guess, to some of the VA, some of the veterans out there. I am a a veteran, 22 years, was in the Desert Shield, Desert Storm, Iraqi Freedom, and spent in my last 10 years of service back and forth to the Middle East quite a bit. I've been to the VA several times, the hospital, the clinics. I do have sleep apnea. I do have, what they've diagnosed as chronic pain, fibromyalgia, I guess, for lack of, they can't figure anything else out. When I go in and tell these doctors, or some of them aren't even doctors, or just PAs, that I've got this going on, this hurting, and it just seems like the same old thing. Well, we don't show anything. Well, there's no, your testing says that nothing's going on. I just wonder, does the new research get filtered down through them? Because it seems like they are about 20 years behind the times when it comes to medical, anything medical. And to be frank, I mean, it's just so frustrating to go there that, I would almost rather go to my own, a different doctor and a civilian doctor and pay for it, because it's that frustrating. Sure. And, and I don't necessarily need the VA like a lot of these veterans do. And I just feel so bad for the guys that are dependent on them, because they have to jump through so many hoops. And I don't feel like they're getting the fair treatment.
Well, thanks for bringing up that point, Darren, and thanks for your service. We really appreciate it. I guess it brings up a good point. Maybe I guess a follow-up question would be, how high-tech do you have to be to diagnose some of these things? Are these things readily available? Should they be available at a local VA, or do they have to come to some specialized clinic like yours to get these tests done?
So there is – I can't speak exactly to what's at the VA, and but they're working diligently and trying to do a good job. But I can't speak to what's there, and I think some of these criticisms are valid at times, because we all have to try to improve. What we see is what the caller was talking about, which we would also embrace, is we do see a significant number of veterans who will come to folks like us, help them get started with some therapies, and then we will partner with the VA and share the information with our colleagues at the Veterans Administration and let them know, because they are frequently overworked and understaffed, and any way we can help and complement that service is a great way to go. So we'll work with that. There are efforts. I would encourage you, Robert Gates, the just retired Secretary of Defense, one of the passions he had was to improve care to the veterans, and he was passionate in fighting the bureaucracy to make that better. I think we're seeing some of the rewards of that. He talks about that passionately. In fact, he said one of the reasons he left service was he was so overwhelmed with emotion trying to care for the soldiers. So I think there's some hope due to some of those efforts. But here in St. Louis, we're blessed with a very strong medical community that's highly sensitive to veterans' needs. And so we're always honored to interact with them.
Most of us here in the St. Louis area did part of our training at the VA.
Correct.
And so we have these interactions and relationships with the hospitals and keep them up. So it sounds like you guys will work closely with the VA to make sure that at least maybe get that patient started down the right path for their care. And
then that way they can get access to care much more inexpensively after we get things started, whether it's sleep apnea or things like post-traumatic stress. The VA is very open to working with private docs these days, from what I can tell. Yeah.
One thing that's going to go against my New Year's resolution here.
Uh-oh. Here we go. We made it to the third segment.
We did. We made it. 43 minutes in. But one of the arguments I heard for how wonderful Obamacare was going to be was they kept pointing to our VA system and how wonderful it was.
I thought you were going to say people were going to be able to sleep better knowing.
That's right. Wait, are you covered under Obamacare, Dr. Joe? That's the most important thing to ask.
Wait, you mean us personally, or
yes.
our services?
Your services, like a sleep study. Is that something that's covered under insurance? No joking. Is that something?
Yeah. So sleep has become very mainstream. So we rarely anymore find let's define sleep testing versus sleep services. Everybody covers sleep services because it's a doctor visit. And one of the big things we try to do is make sure that people get the intellectual care of the physician in sleep services. Sleep testing, 10 years ago, 12 years ago, you used to have a significant number of policies that didn't cover sleep services, like testing. It is rare today. I haven't seen an uncovered sleep test from the standpoint of the policy excluding it in a number of years now. So the answer is, I think most people are covered.
It's just becoming more accepted that sleep affects pretty much every organ system in our body. And so, yeah, I remember being in training, and some of this stuff almost seemed like voodoo medicine. Mystical. Yeah, that's what, yeah.
Here's what's really driven, especially since we both trained, is the effects on things like intractable congestive heart failure, intractable high blood pressure. When we start showing those improvements, the insurance plans have now come around all the way because they see outcomes. Insurance people are very smart people, and they have seen that by treating sleep correctly, it can improve keeping people out of the hospital and keep their well-being better than they're for it.
Absolutely. They'd rather pay for it on the front end than triple on the back end, probably. Okay, stay tuned, folks. Get your calls. Keep them coming in. We've got Dr. Joe Ojile from Clayton Sleep Institute.
There's a time and place for everything.
7-1.
Welcome back. Hope you grabbed your cup of coffee. I didn't. We're out of coffee in here, and now I'm coffee deficient.
We are out of coffee.
So I may be sounding a little grumpy.
We'll see if we make it to the end of this segment.
That's right. If I start falling asleep.
We know what to do.
That's right.
I can cure my sleep problems, Dr. Joe. I can just drink more coffee, right?
Right. Well, caffeine can be used. It is a drug.
It can be used as a drug. So can you prescribe me some coffee for this morning?
I'll give you a script when we're finished.
Okay, great. We've got Dr. Joe Ojile from the Clayton Sleep Institute. Find out more about his practice at claytonsleep.com. He's got offices on Tesson, Ferry, and Lindbergh, and at Big Bend. Is that correct?
And Highway 40.
Office number 314-645-5855. If you missed any of the show and all this wonderful information, you can find it podcast on 971talk.com or on our Facebook page. Just do a search for Illinois Eye Surgeons, and we'll put the link up on Facebook.
Wait, no, go ahead. I had a question for Dr. Joe.
You look like you
I
had
do.
some important points.
I have I got one for the listeners that I think they need to hear.
And then also, one other thing. If you want to try to get a hold of us, Eye on Health at illinoiseye.com, you can email, and we get wonderful emails from everyone. But what I was going to say at the beginning of the show, and I forgot, about 50% of my emails are about how wonderful Eric Robert is. Yes.
That's not true.
It's very true. I'm getting very angry about it. I feel terrible. I feel like they could put anyone over here. It's all your Redbud.
That's right.
Actually, most of them did come from Redbud.
See how that works? Yeah. I can pay him back now. So my question is now, and this is one of the benefits of being here every weekend is, working with Dr. Jones, working with Dr. Tobler in the morning, and then all the things that we talk about. And there seems to be this common theme with all sorts of different specializations in medicine where 80+% of cases can be solved with a pretty simple solution set. Now, it may vary depending on what issue we're talking about. In general, what do people need to be doing better with regards to their sleep? Exercising more, clean up their diet, things like that are just chronic that you see all the time.
So thanks for that. That is such a great question. I appreciate you asking it because it brings up this whole aspect of sleep as health versus sleep as disease, right? So we know that there's sleep disorders, but one of our big our missions is to help people start to incorporate sleep as good health. And the big things people can do for sleep health, first of all, to recognize that it should be part of diet, exercise, and sleep, to incorporate regularity. So going to bed approximately at the same time, getting up approximately at the same time, budgeting enough time for sleep. It is a source. Some patients get rather frustrated when we do a full evaluation, and what's happening is they're sleeping 5 hours and they're tired during the day. Less than 1% of people can exist on 6 hours, healthy on 6 hours of sleep or less. So either they're all coming to see us or folks are that's an issue. So to raise that to a conscious level and begin to incorporate it into their lifestyles. Yes, it is frustrating. We'd all like to have an extra 3 hours a day to work, but how much time you need to sleep to feel healthy is determined at the time of conception. It's genetic. All of us are different. Some people win the biological lottery of life, and they can exist on 6 hours sleep. Good for them. Most of us need, the peak of the curve is about 7 hours, 45 minutes sleep a night. So if we can get between 7 and 8.5 hours of sleep. Yeah. And then diet can affect it. So you don't want to eat heavy sugary foods prior to bedtime. A light, low-fat, low-sugar snack is not a bad thing. Your mom and grandma were right. Something warm, like a little bit of warm green tea or warm milk. Exercise is quite helpful for engendering healthy sleep. Last year, the Sleep in America poll from the National Sleep Foundation, which is the most widely quoted health poll in the United States, will be out next month, by the way.
I'll be looking for it.
We're involved in
that.
that.
You can come right back in and
happy
talk
to do
about
it.
Absolutely.
Yeah. And so, it'll be telling you the subject shortly, but it's embargoed right now. We're on the National Sleep Foundation board, but it's always an exciting topic. But last year we did exercise. And so one of the myths of exercise was we used to tell every patient you shouldn't exercise right before sleep. That's still relatively true, but there are some folks who can get away with that. But exercising several hours before bedtime, one, will help your overall health, but it will make it easier for you to go to sleep. What happens is when you heat up, as you cool, you take a nice shower and you're cooling down, that's very soporific, are sleep-inducing. So all the things you mentioned are helpful. We have healthy sleep tips on our website. We call them, it's called sleep hygiene for the scientists, but healthy sleep tips is a much nicer way to go about it. But the more you can incorporate it, it's better.
Eric, he pointed at me when he said scientist. I
wouldn't be mistaken with one very often. So would you say most folks who come in to see you have some behavioral aspect of their prescription, so to speak?
Yes, most people, because it's our society. We live in a 24/7 society, so it is, for most folks, some aspect of our discussion with them, and we do hit those points: when you go to bed, when you get up, so forth and so on. But there are some people who have struggled for many years, and when they come in, they have been doing most of these things, and it ends up it's their biology. And these people are, after we do some work with them, we'll start to talk to them about other things such as medication. So we're not anti-medication. As we tell patients, we're just agnostic. It's all about what's going to benefit them.
Sure.
So, Dr. Joe, how often do you get a patient come in, and this happens to me quite a bit, you go over all these lifestyle things, and they say, I just want a pill. Can you just give me a pill to put me to sleep? I mean, is that pretty common?
It's common. I suspect you see it in your specialty as well. We have a heart-to-heart talk with them at that point and say, well, here's the good and the bad. We will most of the time encourage them to do some behavioral work before we will prescribe medication. It gives both parties some comfort in that process. And frequently just going through it can be an eye-opening experience for
That's good. I like that.
That's a nice pun there.
the patient.
Yeah, I see what he did there.
Well, you guys are getting all the good lines.
Yeah.
I had to chime in.
He could be a regular.
He could, absolutely.
This could work out.
Well, I'm on the edge of my seat for the study that's coming out, so he absolutely has to come back in when that survey is done so we can hear about it. So, Dr. Joe, with these medicines, is there a chance for addiction with some of these sleep medicines? I mean, here's what I see, not from a sleep specialist point of view, but the patient probably goes to their primary care doctor, and I think the easy thing for the primary care doctor to do, no fault of theirs, but the easy thing to do is to put them on these medicines. I mean, can they become addicted to them? Because I seem to see it quite a bit in my own patients.
Yes.
Not that I'm prescribing the medicines; they're already on them when they come in.
No, so the medicines are considered low addiction potential, but not no addiction potential. You're right, on point. That's why we want to have an explanation with the patient before we give them. Our primary care colleagues are completely appropriate, obviously, in being the first line in therapy. There are, in all studies, and there have been study after study, the issue you were bringing up earlier, insomnia, 10 to 11% of the population. So that's twice the rate of diabetes. So these folks are coming into our primary care colleagues and sharing this information. So if they fail that initial therapy, then it's time. So addiction, the big things we look for is the medicine doing its job and working? Is the patient having any side effects? And are they having any dose escalation? So we see folks to make sure they don't have those three things. If those three conditions are met, we will continue the medication. If they're not, we discontinue the medication.
Do you have examples, and we have just a short amount of time here, where they've already been put on it, they finally get sent in to see you? Are you able to take them off, or once they've started, is it too late?
No, it actually is quite common that we'll wean them off the medication.
Oh, hey, the song's great. Dream is over.
See,
the dream is over with Dr. Joe Ojile. Thanks so much
Thank
for
you
coming
for having
in.
me.
We'll have you back when that survey is completed.
Great.
You're a
Thank you.
gentleman and a scholar.
Thanks so much, everyone. Tune in next week at 10 a.m. for more Eye on Health.
Get more at 971talk.com.